Anyway, so I'm Carolyn. I'm one of the ophthalmologists at Mid Yorks. And what I'm going to do is we're asked just to do a run through of sort of stuff that you may have forgotten about from when you're in medical school. And teaching is quite brief there anyway, in most. I've done it in lots and lots of pictures. So hopefully you can, obviously it's going to be recorded so you can watch it back again, but there's lots of pictures. So you might just need to fill in bits around the edges, but hopefully it'll make it a bit more fun and easier to follow. So most people feel a little bit like a fish out of water when they're dealing in ophthalmology, but hopefully by the end of this, it won't feel quite so bad. We're just going to run through quickly things that people have sort of heard about, but sometimes don't quite understand exactly what they are. So just a couple of slides on some of them, a few more on others that you may come across more often. Most of you are coming obviously towards the end of F2, so you will either have done an A&E placement or be doing it. So some of the A&E stuff you might have just picked up in passing, although obviously with the pressures on A&E, a lot of things have come straight through and gone straight through to the specialties without actually coming in to see you anyway. But I'll cover a little bit of those anyway. And also things that you're going to see on the wards in future, and really in whichever branch of medicine you go into. And just remember a few things that can cause blindness. So think of things why the vision can go down. Everything in the eye is nice and clear. You've got a clear cornea at the front. You've got clear fluid in the bit in between, which is the anterior chamber with the aqueous in. You've got a clear lens, clear jelly at the back, the vitreous. And then you obviously got the film in the camera, the retina, and then all the axons come down from the individual rods and cones and then form the optic nerve. So anything can be affected all the way through, but just bear that in mind when you're trying to work out what's going on with somebody when they come in and say, I can't see as well, or they've got a problem with their eyes. So history is easy. You can all do histories now. Just generally think about, really let the patients talk. They'll tell you what's going on. You don't need to have a lot of background knowledge. But once you start picking up on clues on what the patient's telling you, if you then need to refer to an eye department, just tell us what the patient says, and that will probably give us more information, really, even if you're not sure what's going on, than actually trying to decide what's going on sometimes. So if you just tell us, and we can normally work it out. It's fairly standard, really. And don't forget things in the general medical history, just especially diabetes and things like polymyalgia rheumatica, anything like that that could potentially impact on the eyes. Just bear that in mind. Okay, visual acuity. It doesn't have to be difficult. Most people, most areas will have some form of visual acuity measurement system in A&E. Most GP surgery will have something. If you have absolutely nothing, just use pages on paper, anything that's written down. That'll give you some near vision. It'll give you an idea of what people can see. Can they still see the phones clearly? Do they have to enlarge the text? It can be as basic as that if you really don't have anything else around to try and help. Pupil reaction, visual fields, just think quadrants. Very simply, you don't need to go into lots of details. That'll pick up most things, especially if you're thinking of a stroke. Pupil reactions, people get a little bit confused about this. What you really need is, we need to know whether the optic nerve is working. So you can shine a light in one eye, look at the reaction, is it constricting, shine a light in the opposite, then see whether you've got a consensual. So is one eye following the other eye? So is one pupil following the other pupil and constricting, because obviously they work together. That's really what we're interested in when we're trying to work out whether the optic nerve's working. So we then swing the light between the two eyes and you look at the speed of constriction of the pupil. If there's any difference, that might give you an indication that the optic nerve isn't doing its job. And that could be why the vision's not so good. So it's a relative response. It's a difference in speed between the constriction of the two pupils. Only really by the time you've got to that point, think of the front of the eye. And you don't need to have much equipment, just a torch, just a pen torch really, and failing everything else, just a light on a phone, although they are really bright. So people will find them quite difficult to keep their eyes open if you're trying to use a phone light. I know you can dim it, but just be aware of that. And only really when you've had a look at the front of the eye, do you really need to think about looking at the back of the eye and then the fundus. And most people, unfortunately, when they think about examining the eye, sort of are looking for an ophthalmoscope to drive in straight look at the back of the eye, but think of all the other stuff that's going on first. Traditionally, we look at a big letter at the top of the chart, and that's got a number in it called 660. We do it in meters in the UK, 20/20 vision in the States, because they still work in feet. And it's just a rough idea of how far people can see down the chart and whether that's the same as it was before. So just very quickly running through things like cataracts, this is what it is. It's just a cloudy lens. So it's this bit here that can go cloudy, and they can look very different. You can be born with cloudy lenses, you can have congenital cataracts, you can get them because you take certain medications such as high-dose systemic steroids. That's likely to give you a cataract in your 30s. If you take lots of inhaled steroids for asthma, you can get cataracts earlier. It's just one of the things they do. Other conditions do predispose you to having one, but we're all going to get a cataract if we live long enough. It's a bit like grey hair. It's an aging change in the lens. Some people may not get it until they're in their 80s, some even later. We often see little bits of cataract in people when they're examining them, and people get quite upset sometimes when they come to clinic and they say, oh, the optician didn't tell me I had a cataract. Well, we see them so often, and unless it affects people's sight, we actually don't need to do anything about them. But most people do have something over the age of about 80. Here's just a few pictures of cataracts just to talk you through. This one here on the top left is a really dense one. That's white. Patient can't see out, we can't see in, there's no way that they can do much. But the pupils will be a normal reaction. So that even though you've got such a dense cataract that somebody can't see out, the light that's getting through will stimulate the optic nerve to work normally. So the pupil reactions will be normal. This is obviously a clinic one, patient's been dilated so we can get a look. So that's a nucleus sclerotic, that's generally affecting everything. You can get some that just affect certain parts, like a polar cataract, so that's just a dense cloudy bit in the middle, and everything else around the edge is relatively normal. And the other one, this one here, it's got sort of spoke-like, and that's a cortical cataract. That's relatively common. So the two most common cataracts are sort of there. So cortical lens, nucleus sclerotic, and posterior subcapsular or polar ones. So what do? Not often, we don't actually need to do anything. So we do an operation if it's affecting the person's vision or they want to carry on driving. I put 96% patients see better after surgery. The updated results from the College of Ophthalmologists for our trainees who are leaving the training scheme, they have to audit 300 of their cataract operations, and their own individual audit results need to be a complication rate of less than 2%. So in fact, even for our trainees, there's very high success rate. It's all local anaesthetics, predominantly day case, and it is the most common operation done in the NHS. And unfortunately, not many people get to see it. But there's plenty of videos on YouTube and out there if you need to actually watch them. If it goes well, it's a very successful operation. Obviously, there will be a few people who don't do so well, and we do have to counsel people against that. And if you've got certain conditions, then the chances are you might have high risk of complications. So if you've had previous trauma, that's the most common. If you have other conditions that affect the vision, such as macula, we're going to talk about later, and that can affect your cataract outcome. So the three biggest, just to go on why I've done this talk in this way, cataracts, glaucoma, and retinal disease are the three biggest blinding conditions in the world. So cataract is a massive unmet need in most of the world. So that's one of the top three causes of blindness. So if you get surgeons in there, then that's a reversible cause. Glaucoma is the second commonest cause of worldwide blindness. And it's also relatively easy to pick up and treat if you're in a Western society. But it's the detection that's the most important, because most of the glaucomas don't have any symptoms whatsoever. So it's a bit like having high blood pressure. Unless you look for it, you're not going to necessarily find it. But that's why I've done this in this particular way, just to give you a rough idea of the sort of the importance of the conditions that we see in clinic. So what is it? It's basically an optic neuropathy. So when you look it up, there's lots and lots of different types of glaucoma, but the end result is they all damage the optic nerve. And once that's gone, it's gone. We can't reanimate that. So most commonly, there's too much fluid within the eye, causes a high pressure. The pressure squashes the central retinal artery, which comes out from the middle of the optic nerve. And when that goes, you get an artery occlusion, you go blind. So that's basically it. It does do some other things slightly, but that's, if you think about it like that, then that's the easiest way. There's actually no cure for most glaucomas, we just control it. And the main ones are open angle glaucoma. That's the majority that we see in our clinics, and the majority of people that you'll come across when they're inpatients on the ward will have open angle glaucoma, and they'll probably be on just drops daily. The other one that's important not to miss is one of the emergencies, and it's the cause of a painful red eye, and that's closed angle glaucoma. So I'm just going to very quickly just go through those and just reiterate the difference between them. There are other secondary open and closed ones, but you don't need to worry too much about those really. So the reason we call it an angle is that if you think of the cornea and the angle that the cornea, underside of the cornea makes with the iris. So if you look at somebody's eye, you just basically see your cone of the dome, sorry, of your cornea. And then underneath that merges with the sclera on the tough outer part of the eye. And then underneath that, you'll see the iris, which obviously moves when we do the pupil reactions. And it's the angle of insertion between the iris and the cornea coming up that gives us these terms. So if it's open angle, it's a wide open angle. So there's lots and lots of space there. And there's little drainage channels right next to this. And that space needs to be open so that the fluid that's made at the back through the ciliary body flows around the front, just like the CSF, and then drains through this canalocele. If that gets squashed and the drainage channels get blocked, then the pressure can go up. And that's the difference between the open angle glaucoma and the closed angle glaucoma. So when certain conditions are met and this angle just closes up, that's when people get the acute, painful, sore red eye, which is the absolute emergency that we need to treat when they come in through UK. So this is just what I was mentioning earlier. It's really common. 2% of the population have it at the age of about 40 and 10% have it. Others will have it by that time we hit 80. You're more likely to get it if you have diabetes. You've got high risk if you've had it in the family. If you're very short-sighted, you're more likely to get it. And Afro-Caribbean origin, you're more likely to get it as well. It's just the way we're designed. So the mainstay is checking the pressure in people's eyes, looking at the visual fields, which is how we monitor, and we also look at the optic nerves. So when you look at patients for particularly other reasons, you might look at them and see a disc that looks like the one down the bottom right, which is very pale, and the vessels look like they're disappearing over down off the side of a cliff. That's cupping, and that's advanced glaucoma. So you've got a normal disc up above, and then this white bit in the middle, which is just a bit small up here, just grows and grows and becomes bigger, and that's the cupping, and that's where the damage has happened, and that's what we're trying to prevent. So just hold that thought of what that disc looks like, because we'll just have some discs, other disc appearances later on, which obviously everybody worries about swollen discs, but there are other things that we can look at discs. So to treat it, just drops, lots of different ones. You don't need to go into particular details. Some slow the production of the aqueous, so it comes out more slowly. Some increase the outflow. And rarely nowadays we can do laser, and we also can do surgery if we really can't control the pressures of the drops. Most people do really, really, really well, and most people retain vision, although it is a cause of blindness, like I said. But what the idea is that we slow it down to such a rate that the graph from where you potentially might lose vision is after the patient's passed away, so well into the hundreds. It's been plotted. There's loads of clever people have done lots of research to work out what trajectory patients are on and how they're going, and that's what we're trying to modify. We're trying to slow down the progression of the disease until the patients are no longer with us. And just to mention the angle closure, just to, oops, sorry, my fault. Just to show that when that angle gets closed and that little channel gets blocked, thence when the pressure goes up acutely. And what happens then is that the little cells on the underside of the cornea can't pump fluid anymore. So they stop working and the cornea goes hazy. So when you look at somebody with a really painful eye, tend to be 40s onwards, and it's just looking hazy. You can't see the iris details very clearly. And the pupil tends to be fixed as well. It doesn't move because there's ischemia in the iris and the muscle just stops working. And that's part of the reason why it's painful, because they get cramp in the iris muscle and the pressure just goes up. So that's the acute emergency that we don't want you to miss. So if you see somebody who's got a very painful red eye, they're in the right age group, it's come on relatively suddenly. If you just very gently touch the top of their eyes, if you touch your own eye now, there's a little bit of give. If you very gently touch somebody's eyes and you're not sure whether they've got a red eye that's due to whatever cause an acute red eye can be due to, but specifically thinking about glaucoma, if it feels hard, and it will feel different, then you're probably likely to have acute glaucoma. It's a really simple test. You don't need to worry about doing anything fancy, but it might give you the answer. Okay, so what do? Well, we try and lower the pressure by getting rid of the fluid, and we do that by using diuretics, most commonly Diamox, and we give that IV. It's an old-fashioned sulfonamide antibiotic, but it has a really good diuretic effect. And to a certain extent, we do that in A&E. And in the past, I've had people, A&E docs who've been, well, one particularly who was working in Dewsbury not long ago, he said, after everything, I've got somebody with acute glaucoma. And what with one thing and another, the patient didn't have transport. We had to go and get them. That person actually did start IV Diamox because the patient wasn't allergic to sulfonamides. And that is the best thing to do, is to start treatment as soon as we can. And then we try and constrict the pupil to physically pull it out of the way of these, the angles, so that these drainage channels, so that it actually allows it to drain again. And then long term, what we need to do is try and stop this happening again. So we use a laser and we actually fire a little hole into the corner of the iris, and that keeps the fluid draining and stops this happening in future. And it's a peripheral iridotomy. So that's what we're trying to do. And what we'd do is, if you've had acute glaucoma in one eye, we'd do laser treatment in the opposite eye so that it doesn't happen again. Okay, so brief run through the top 2 blinding conditions in the world. And this is a scary picture. It's causes of red eyes. There's loads of them, and there's a top 50. You don't need to know all of them, obviously. What people are really concerned about is not missing something that's important. So the angle closure glaucoma, really important, because we need to get treatment on early. And of the other ones, I'm just going to run through a few. Some are really important, as in you need to get treatment relatively soon, within sort of 24, 48 hours. Others not so, but they're just really, really common. So you'll just see a lot of them. So it's very difficult to do questions and answers when you do these presentations, but have a think. If you've seen somebody who's 18 years old, got a little bit of a pink eye for a couple of weeks, otherwise absolutely fine, bit watery, a little bit sticky, he's had some ointment from the GP, hasn't really done much. What would you think it is? Hold that thought in your mind, because in a minute I'll give you the answer. So most common things happen commonly, and most red eyes are really common things, and the most common is conjunctivitis. And the most common one of those is viral conjunctivitis. There's also allergic, as those of you who get hay fever know that you'll get red eyes when you get your hay fever. So those are the 2 most common ones. Like I said, most are viral. We always give chloramphenicol as a starter for 10. It's a broad spectrum antibiotic. Very few people have reactions, although obviously you can get a reaction to any medication, and it's relatively safe. It doesn't cause any problems, so we give it to babies right up to the elderly. And what you've got is a nice clear cornea. So the reflections of the equipment used to take this photograph are nice and clear. So that's the difference between that and maybe an angle closure, is that the reflections are clear. You can see the iris really nice and clearly, and you just got sort of a bit of redness on the conjunctiva. Pulling the eyelid down, bottom, you might see some horrible stickiness if it's a bacterial cause. Don't forget chlamydia as well. So notifiable, it's obviously a sexually transmitted disease, and it's contact traceable. So we would always send people off to the appropriate departments in a community if we thought we had somebody with a chlamydia conjunctivitis. And you just get red bobbly bits down below, and it looks very similar to many of the other conjunctivitis. It can be difficult to tell. So if it's sticky, we do a swab, we give topical antibiotics, and then if we think it's a viral, they've got other things going on, like don't feel unwell, they've got lymphadenopathy, and they generally look like they've got an upper respiratory tract infection or something similar, then you can just lose lubricants. If you've got a red eye and a bit of itching and burning, just think about whether you've got this thing called blepharitis. This picture just shows basically dandruff on the eyelashes. 1 in 10 of the population have it. It's really common. But the difference between that and, say, the history I was telling with Kevin with the pink eye is that it tends to be chronic, much longer time frame, and people have sort of times when their eyes are itchy, sore, they get a bit red, and they might get a bit better. And that's due to the bugs and bacteria on the skin getting involved in the glands at the base of the eyelashes called the meibomian glands, and causing basically irritation. Other causes of itching and burning and red eyes, dry eyes is the other really common one. And then I've just mentioned allergic problems, hay fever most commonly, and then some medications, obviously. So people can become allergic to the contact lenses as well, and they can become allergic to anything, usually the preservatives that we use in glaucoma drops. So there we go, actually blepharitis. It can give you a whole host of symptoms. So if you go into general practice, people can come in complaining of all sorts of things, right down from sort of burning, dry, itching, sore, watering, blurry. They can even lose eyelashes if it's chronic. It causes sort of chronic inflammation at the base of the lashes, and then they can go, and of course, red eyes. So what do? I spend a lot of my time in clinic telling people to clean the lids in a very nice, positive and uplifting way. If you're a gent, you're probably not necessarily, although I don't want to prejudge anybody, but most ladies are very used to taking eyeliner, mascara, makeup off on a reasonably regular basis, depending upon personal preference. And paradoxically, if you're cleaning your lashes regularly, if you're taking makeup off, you're naturally cleaning the base of the eyelashes and getting rid of the bugs and bacteria and the build-up from the meibomian glands. So we originally used to say things like baby shampoo, you can use a bicarbonate solution, so a teaspoon of bicarb in some cooled boiled water. But the latest research seems to be showing that if you use preparations that have tea tree oil in, not the neat tea tree, don't go anywhere near that because it can sting, it's really too harsh. But there's quite a lot of preparations on the market in the forms of gels and wipes that can seem to have a more beneficial effect. And it might be the tea tree is having either an antibacterial or an anti-inflammatory effect. So cleaning, warm compresses can soothe the eyes if they're really sore. You can use either a warm flannel, or you can buy wheat bags or things that can go in the microwave just to warm them gently. And there's lots and lots of markets. So if you go into chemists and opticians, they'll see a whole rack of things that can help blepharitis. If the simple things don't work, artificial tears as well. Any artificial tears, there's loads on the market. Ones that have hyaluronic acid in are very good for soothing. So if the eyes are sore and gritty, then any artificial tears. Sainsbury's own brand dry eye drops, about £3 a bottle, are the cheapest and very good. But patients often, if they're using them for a while, will find out which suits them best. So anything to make them feel more comfortable, clean the eyelids, give them artificial tears and warm compresses. Failing all that, we can give azithromycin or tetracyclines. We're not using them necessarily, we are using them a little bit for the antibacterial effect, but they seem to have a stabilizing effect on the gland production as well. And azithromycin seems to be just as good as tetracyclines for 3 months and easier for patients to use. Also, some research is coming through that omega-3 fish oil capsules are really useful, just the ones that people can get over the counter. So you can either have the 300 milligrams, which is what normal supermarkets sell, or you can go to Holland & Barrett or Boots and get up to 1500 milligrams. We really don't know which is the best one, but in some people, they take away the itchiness, which can be really beneficial. And we genuinely really don't know why it works. In some people, there's always those that don't settle, and it's a chronic ongoing condition, and they bounce in and out of eye clinics. So just be aware of that if you end up in general practice. There's not a magic cure, and it's a lifelong problem. It's not something that we cure with a short course of treatment. It's the way people are. It's like having dandruff. So that's my bit about blepharitis. It's really common, and it's not always easy to treat. So then, have a quick look at this photograph and mentally have a look and see what I've just been talking about. Can you see the iris clearly? Does the cornea look nice and clear? And is there anything else that you can see floating around there? I'm hoping that most of you have noticed that you can't really see the cornea very clear, the iris very clearly. It might be a little bit hazy on the reflections from the camera, and there's this white fluid level there. Hopefully some of you will remember that. But we're now going just to move on to corneal ulcers. So this thing here is called a hypopion, which is a collection of white cells. White count cells can be there because they're from an infection, or they can be there from inflammation. So we'll talk a little bit about inflammation a bit later. So contact lens wearers. I wear contact lenses, loads of us wear contact lenses. Unfortunately, most of the infections that we see are contact lens related. They tend to be bacterial. Acanthamoeba, which is a protozoan which just lives in our tap water, can also has an affinity for contact lens material and sits itself there and could cause a nasty ulcer, which is why you're told, hopefully told, to be very careful about showering when you're wearing your lenses, especially if they're monthlies, because the amoebae can stick to them, and that's when they cause problems. Daily disposal is not quite so much of an issue. You can just get a localized area where there's a little ulcer or a break in the epithelium, or you can get multiple areas. And obviously, the unfortunate patient won't be able to see particularly clearly through that. If you are suspecting a corneal ulcer in any shape or form, clearly we need to know about it from the eye department, and we would always see somebody relatively quickly as far as we go. You can also get, if you're immunocompromised, you're much more open to having fungal infections, and that can cause some quite nasty corneal ulcers as well. Okay. This is something that causes a painful red eye and is treatable, and anybody can start treatment for this. So those people who know that they've got cold sores or they've had a cold sore infection in the eye in the past, will probably recognise that when it's coming back. As you know, cold sores are recurrent. Same thing as you get as a cold sore, the herpes simplex virus in your cornea, it can come back. Put a bit of yellow dye and it looks this sort of typical branching appearance. And you can start, you can start treatment. It's usually this is 5 times a day, which isn't normally how often we give drops or ointments or even medications. It's a safe ointment, so even if you're not sure, but you might have somebody who's got a viral ulcer, a herpetic type ulcer, if you start ganciclovir, you're going to do the patients a world of good, because even if it turns out to be antibacterial, the chances are, if it is a viral herpes simplex one, you're going to do the patient a world of good, because the sooner we get treatment in, the sooner we can stop the virus from penetrating deeper into the cornea and causing endless problems down the line. Getting it at a superficial stage is really the goal of our treatment, because if it's left, the virus can burrow itself into the cornea and then cause reactions in the anterior chamber and cause a keratitis, which is anything to do with the cornea, and it can cause a uveitis, and then you can end up getting scarring and loss of vision. And then we might end up having to do one of these, which is an old-fashioned corneal graft, which is when we take a button from a donor cornea, basically, and replace the bit in the patient's cornea that's scarred. Okay, so a little bit about lumps and bumps. Most important thing about lumps and bumps is that some are innocuous, and if they stay at the front of the eye, so in the skin and the surrounding tissues, they're usually relatively easy to treat. But if you've got something like this young gentleman on the left, who's got quite a swollen eyelid, the importance obviously is to see whether that's gone further back into the orbit, and rather than just causing an inflammation or infection in the front of the eye, in the skin and the muscle, we need to know whether it's gone further back into the orbit. So on the right here, you've got a very localized infection. That's probably a problem with the meibomian gland. That can, in some instances, progress to something like this, but it's rare, although people do tend to get systemic antibiotics if it looks like it's taking off. And this is the time when we need to know what's a little bit of anatomy, not a lot. Basically, if you take the skin and the orbital septum out, when you look underneath it, you'll get the orbital fat and you'll get the lacrimal gland and the tear drainage and all the muscles and all the nerves. And then surrounding all that, you've got the bony box. And that's really where the problems come when you get infections or anything that's going to cause swelling around the eye, is the fact that there's nowhere for the swelling to go. And you get a compartment syndrome. So that's really why I bob these in, is just to remind people that if it goes further back, there's nowhere for the pressure to decompress. And there's this membrane. There's 2 different pictures. So this membrane comes off your brow, and then goes down and fuses with the muscle that lifts the eyelid up, the aponeurosis muscle, because the levator muscle, and it can fuse quite high up and give you a high skin crease, or depends which part of the world you come from. You can fuse quite low down where you don't tend to get much of a skin crease, but it's the same sheet of muscle. It's a septum, sorry, sheet of tissue. It's the orbital septum. So you've got the skin and muscle in front, and then you've got the orbital contents behind. If the infection stays just in the skin and muscle in front and doesn't go through this septum, then you've got a preseptal cellulitis, and we're not so worried. If we've got any concerns, or it's a young child and we really can't assess them very well and we think it's gone through to the back, that means that we need to obviously take it a little bit more seriously. Because what can happen then is you can get abscesses, for crying out loud. Abscesses, often the infections come from the sinuses. So you can see here that you've got some opacity in the ethmoid sinuses, and this particular, she was a young lady of 4. And she had a subperiosteal abscess, which you can see is pushing the medial rectus across, whereas on this side, it's all nice and black, and there's no infection on that side, but there is obviously here. Luckily, she was due to go and have drainage of the sinuses a few years ago when she presented, but what with getting theatres organised, her temperature dropped, and she actually managed to decompress herself, so and then ended up not having theatre. But that's why, if you've got any concerns with a child, they get admitted under PEDS, and ENT and ophthalmology have input, but predominantly PEDS look after these for us. Okay. Contact lenses and laser surgery. I've just popped this in just for people who don't wear lenses, and just because I get asked a lot of questions about this normally. So there's 2 main types of lenses, soft and hard. Most people nowadays, 99.99%, have soft lenses. They're the ones that unfortunately are prone to having the acanthamoeba stick to them. And obviously if you're handling them and you don't wash your hands, you're more likely to introduce bugs into the eye. So hand hygiene is obviously very important. Rigid lenses we do use, especially for conditions such as keratoconus, which is where the cornea changes shape, and they will correct quite a lot of the changes in vision that you get from the fact that the cornea is changing shape. So hard lenses are what we use to correct that before we may do treatment for keratoconus. But soft lenses are the most common. As I mentioned before, infection is the most common problem. You can get long-term corneal damage and you can get a droopy eyelid, but that's just one of those things that just wearing lenses causes, and we're not sure whether it's because you take constantly stretching the eyelids when you're taking them in and out. So very briefly, just a couple of slides about LASIK, or laser-assisted in situ keratomileusis, which is basically laser eye surgery. And what happens is that we reshape the front of the eye, because the cornea does most of the focusing power of the eye. We change the shape and change where the light rays can focus on within the eye, and make sure they can focus on the retina, so that you don't need your glasses. So if you're short-sighted, you need your glasses to refocus the light rays onto the retina and make the images sharp and clear. And that's what the laser eye surgery does. It changes the shape to get away from having your glasses. Unfortunately, you'll still need reading glasses when you hit the age of about 40 to 50, because the changes within the lenses within the eye means it makes it more rigid and it can't change shape. So that's the lens that is also changes. So when we're looking at things close to and near, it's the muscles within the eye and change the shape of the lens. So the cornea has a lot to do with focusing the vision, but that's static. And then the lens itself changes shape, and that does the focusing up until the age of 40, when we start needing reading glasses. Having laser is really good for the majority of people, but some people do lose vision if you get scarring. Some people get halos and ghosting, double images and some glare. Most people do really well, but actually if you look at the figures, it's not as great as you'd hope. Some people need more laser because it changes over time. So although it's really good, just be aware that when you're young and in your 20s and 30s, it can be a panacea, but it will mean that it doesn't mean that you won't need glasses when you're older. And that's really what they do. It's just, we lift the front of the cornea, we lift the epithelium off, we reshape the cornea below, and then pop the flap back. So this is the lifting of the flap is the bit that can cause the problems, and the scarring can happen later on. And you can be left with a very fine haze, which for most people isn't necessarily noticeable. But if you use your fine vision for work, or you get glare, it can be really troublesome. So that's why most of us who are cataract surgeons don't actually have laser eye surgery, just because we're cowards. And to be fair, if I had that, it'd be really difficult for me to carry on working, doing the fine work I'm doing. So I'm basically a coward, so I wouldn't have it done. Okay, so if you do want to think about it, it can be really good if you have certain sports you need to do, activities. If you work on a pipeline in Siberia and your contact lenses freeze onto the cornea every time you go out, then clearly laser eye surgery is good for you. So there are instances when, you know, it's really ideal. It is basically a cosmetic procedure, so just think carefully. If people are thinking about it, because like I said, I always get questions about it, federal FDA.gov have a really good website, and there's sort of questionnaires, and it has a lot of detail, a little bit more than the nice one does, as to whether you're suitable for having it. So we've done quite a lot of the front of the eye. Now we're just going to have a think about macular things. Now I've got a video which may hopefully run. We'll see if it's going to play the game. No. Oh no, hold on, let's give it a go. Tell me if it works. If it doesn't work, please let me know.
We see.
Wow, so that's my retina.
What you can actually see there is a lot of blood vessels.
Yeah, that's the optic disc where all the nerves with the information from the retina go back to the brain.
Yeah, the optic disc is the collection point and exit of all the nerves that are in the eye.
And these are the retinal blood vessels.
That's right. So the darker ones are veins, because they carry deoxygenated blood.
Yeah.
And the lighter coloured ones, the thinner ones, are arteries. And then there's a specialised area of the retina, which is over here. It's in this broad area here. And this is called the macula. And the macula is the part of your eye that does all your detailed seeing. So when you look at a book or look at the TV, it's the macula that you're actually using.
But this crucial part of the eye can deteriorate as we get older. It's known as macular degeneration.
These light-sensitive cells start to break down.
Right.
And eventually they can cause scarring, and the scarring in effect creates blind spots in your vision.
Right.
Well, we'll show it in its advanced form where you have large amounts of scarring.
That looks horrendous.
And this person will not be able to see, this person will be registered blind.
Really?
So,
would they be able to see around the edge?
Yes, they can see around. If you look, the edge of the of that area is normal, so they can see normally.
So they've still got peripheral vision, but
Yes,
actually
but
in the
the
centre they've
centre
lost
has
it.
disappeared, and the centre's the bit that's crucial.
When the macula is damaged, everyday tasks become difficult or downright dangerous. So what can we do to reduce the risk of it happening?
We can do something about smoking. Smoking reduces the amount of a pigment at the back of the eye called lutein, which has a protective role.
That protects
against
ultraviolet.
ultraviolet
Yeah.
light. And so without that protection, it may well be that the ultraviolet light subsequently then causes damage to the back of the eye.
Someone who's learning to live with macular degeneration is Danny Gleason. In his case, it's genetic. He's registered blind, but he's determined it's not going to slow him down.
Macular degeneration is like looking at everything that hasn't got a middle in it. If you could get some spectacles and put 2 blobs of Vaseline straight in the middle and then look ahead, that's what it would be like. Your brain's very clever. You know what newspapers are which just by the front covers. You can get the Express and the Mail mixed up. Yeah, they can be very similar. So you buy the Times. As the bus comes along, you just see, you don't know it's the bus coming along, of course. Then as it gets nearer, you just see the shape of it. But then you realise it's a bus. You've got no idea what the number is or the destination on it. And by the time it does get near enough so you can almost see the number, unless you stick your hand out, 9 times out of 10 it just sails past and you've missed it. When I go down the pub to meet my friends, when I walk through the door of the pub, you just don't know who's in there, you don't know who's looking at you, you don't know anything, because you look at everyone and no one's got a face. I had a specialist say that I'll always have a peripheral vision, so I'll never actually go blind, and I'll always be able to get to the pub even when I'm 80, so, you know, life can't be too bad, can it?
Okay, so that I've mentioned, hopefully you did hear that. I sort of mentioning that because a lot of people that are going to be coming through that you'll be looking after in all sorts of branches of medicine, if they're over a certain age, macular degeneration sort of is a 60s onwards condition, might have quite severe macular degeneration. And it's just being aware and appreciation that they can still see, but they can only see the peripheral and they can't see to read. So they can still navigate in familiar circumstances, but they just might need help. So just bear that in mind. We can treat wet macular, dry we can't, wet we can treat. We can stop it progressing, and we need to pick it up early. So there's a 2-week wait for getting patients into clinic who start having distortion or problems with the vision, and opticians are usually the first port of call for most people. And most opticians now have scans, OCT scans, so they can look at the layers in the retina and see if there's any fluid starting to build up, because that's the earliest sign, is leaky blood vessels at the back of the eye before you get to the stage of this bleeding and scarring, and that's the time to pick it up. We give monthly or bi-monthly or even 3-monthly injections, depending on which compound we're using, which is an antivascular endothelial growth factor. And these growth factor inhibitors stop these new vessels from growing. So it's not a cure, because they need injections regularly. You'll find some people have had 15, 20 or even more injections. It's to slow the process down, to keep people independent, to keep them living at home, to keep the quality of life. But there is something we can now do, which is great. And we have a lot of people coming through clinic with those. Loads of you will come across people with diabetes. Diabetes gets into every branch of medicine. The main types, the non-proliferative, proliferative, and then the maculopathy. So this sort of ties in with what we've just seen with the macular degeneration. Leaky blood vessels are a cause of problems all over the body, and the leaky ones in the macular degeneration are quite deep. They're in the choroid, whereas the leaky ones in diabetes are the superficial ones, the ones that we can see. So they're the retinal vessels. So the slightly different vessels that are leaking, but the underlying problem is the same, that they're leaking. With diabetes, we can use the vascular endothelial growth factors, but what we really need to do, it's not a first-line treatment, is we need to sort the diabetes out, get it under control, and then try and sort it out. So that, because that's obviously not a way of managing diabetes long-term. You need to actually get to the root of the matter and actually sort that out. As with anything, your diabetes, if it gets worse, can affect the eyes as well if people are tipping over into having diabetic eye disease. By the time you get in kidney failure, you're probably starting to get eye problems. They tend to go together. It's the same for small vessels that are affected, and also it's a systemic problem. So if the kidneys are starting to not work because they're getting affected by the diabetes, the retina's probably starting to be affected as well. So if we see stuff, like I said, they tend to go together. And obviously we need to sort everything else out. I understand most of you have obviously done your A&E attachments or currently on it, and this might have been quite useful earlier on, but we'll just run through really how to deal and manage. So anybody can get an eye injury, but as usual, it tends to be gents, so it tends to be younger. King Harold didn't do so well either. Take a history, type of trauma. We'll point to the type of injuries that we might be thinking about. If you've been thumped on the eye, you might, if it's just been a fist, it might just be blunt trauma, but then if they've got a ring on, it might then turn it into a wound where you're more worried about whether you've got a cut into the eye. Obviously road accidents, squash is the typical one for sports, where the squash ball just fits inside the socket, which is annoying. And then obviously the others, people working on construction sites, chemical injuries, that sort of thing. Always just remember the tetanus status, I'm sure you do, and we need a general medical history just to make sure we know what else is going on to manage them. Like I said before, you don't need a lot. Just a torch, a drop of anaesthetic to make the eyes numb, give it time to work, and then a vision chart if you have one, and just some yellow dye. Always check the visual acuity. It's sometimes when people come in with trauma, it's something that gets a little bit forgotten. People sort of dive in and think about it, but we need to know what people can see, because that's a very good indicator of how they're going to end up. So good vision on presentation equates with good vision further down the line. It might look quite dramatic, but don't panic. The skin around the eye heals really well, and you can actually end up with a really good result. These are the sort of injuries that can cross over between max fax and ophthalmology, and plastics as well. If you've got a swollen eyelid, it's not an excuse for not looking at the eye. Just put a drop of anaesthetic in and be gentle, and try not to squash the eye. Just lift the eyelids up from the orbital rim. Air gun pellets, anything can cause problem. This young gentleman was quite lucky. It just sat around the outside of the eye. You think, great, it hasn't gone in. But actually the force of it, when it obviously stopped moving, shook the eye. So he ended up with retinal detachments and all sorts of other problems. So even though the injury might not, you think, oh, great, they've got away with it. It hasn't pierced the eye itself. It can cause problems internally. And that's really what happens when you get a thumping injury. It's the changes in the velocity of the tissues moving within the eye that can pull the retina away and cause problems in the back. Subconjunctival hemorrhages, they can look incredibly dramatic, but they are just innocuous. They can be spontaneous. Always ask, obviously, what caused it when it came on. Gardening injuries, people walking into branches and getting things poked is the most common. So this lady, she's got dramatic bruising. It's difficult. She could have just fallen. She could have had a fall. That's the most likely cause of the bruising. She's caught the side of her face. But actually this was iatrogenic. When we did a subtenons injection when I was a trainee a while ago, we actually caused a retrobulbar hemorrhage. And those are the ones that are really important not to miss. And Max Fax see quite a lot of retrobulbar hemorrhages with orbital fractures around the globe. And that's where we think about the compartment syndrome and the bony box, and the blood can't escape. So what we would do is we'd release all the tissues, and this lady's got a little wound here where we've released all the tissues and let everything just move forwards to decompress the orbit. She did do quite well. It just settled down in time. So what we need to do, so if you've got a lady coming in like that, we need to look at the optic nerve, because we need to know whether it's swollen, whether it's being squished. So this is a normal one with a little pale central cup and sort of an amber colour around the edges, and then all the blood vessels come together and disappeared into this little cup. If you think of it as a little cup, they do literally drop into a little hole. Swollen discs are something that people really get concerned about and really worried. If you've had something where somebody's got raised intracranial pressure and it's dramatic, it is barn door. You're not going to miss it. It really does look obvious, even if you're just looking and you're not very experienced with a direct ophthalmoscope. Things to look out for are the little hemorrhages. That shows that it's acute. So if you see little hemorrhages, what we call them little splinter hemorrhages around the disc, and obviously if it's as big as this, with everything's looking blurred and you've lost that central cup, the most important thing is to look for that central cup. So you've lost this little pale area in the middle. That's the salient thing to look for. If you're in clinic and you're not sure somebody's got IH, idiopathic intracranial hypertension, IIH, you can get areas where they're a little bit blurred and where it's not. On the whole, we do sometimes pontificate, but most of the time it's relatively easy to see. And we've got scans and things that we can do nowadays to give us a bit more information. So if you've seen a swollen disc once in your life, you will always remember it and it will be easy. But I understand, obviously, it's very difficult when you're not sure, and it's difficult. You haven't had practice using the kit, but just try and have a look. It's still a skill that's worth having, is using the direct ophthalmoscope. Things that I'd hope you might be able to treat are taking off corneal foreign bodies if you've got time, or little things that stick underneath the eyelid. Turn the eyelid over with a little drop of anaesthetic, and you can sometimes just remove those with a cotton bud. Bigger abrasions, I'm sure you've all seen large corneal abrasions. This is an abrasion. It's probably about 3/4 of the coverage of the cornea, so the edge of the cornea is around here. That will heal amazingly within 24 hours. Most of them are gone at 48. They healed really quickly. We always give chloramphenicol ointment, not necessarily because you don't need to necessarily give an antibacterial, but it's very good at lubricating, so it makes it more comfortable for the patients. But what we audited corneal abrasions seen in A&E, and then obviously booked in to see as an eye clinic. And so like 50% of patients fail to attend, even a following day appointment, because they're starting to get better and they don't come. So we would always see them, but bear in mind that a lot of people don't come. So if we get a referral in now, we'll probably call the patient first and see how they're doing rather than actually booking them in. If you get a pressure change within the eye, you can burst an iris blood vessel and then they can bleed, so you can get blood in the anterior chamber. So this is obviously about 50% hyphema. So hypopion is white blood cells, hyphema, red blood cells. You can get localized ones. So if you've got an eye, just have a look really. And then if you've got an opening in the cornea, if you've got a laceration, the pupil might be distorted. And when the pupil starts to come out, when the iris starts to come out of the wounds, the pupil gets distorted. So that's a really important sign. Look to see if the pupil's nice and round. This is obviously much more dramatic. You've got a laceration that goes from mid-cornea right through to the sclera, and then the iris has come out. You've got a misshapen pupil, but you've also got a black area here. So that's really important. You don't need much training really. Just have a look and see if it's around. And as I mentioned earlier, squashing injuries can cause a detached retina. And when you're looking, that can actually just look a bit sort of hazy and a bit difficult to focus on the retinal details. The retina is actually a greyish sheet, and when it comes away, you just see a sort of a grey fold. Mentioned a bit about acid and alkali. It's an absolute emergency. There are other things that we can use, but washing out with lots and lots and lots and lots of water is a first line treatment. And paradoxically, if you've got a white eye, somebody's had strong alkali in their eye, and you examine them and they've got very white eye, that's actually quite bad. It means they've got a lot of ischemia, and all the blood vessels on the conjunctiva have closed down and been, which can be a bad thing long term. Because if you've lost your conjunctival vessels and the cornea becomes basically ischemic, the conjunctiva grows over and you get lots of scarring, and that's really sort of tough. So that's what we're trying to prevent long term. Oh, sorry, let's see if Natalie's going to play.
Hi Natalie, thanks for coming on and talking to us. Can you tell us what the problem is with your eye?
It's really red, and when I woke up I thought I had something in it, but it's just a bit sore.
And is your eye painful?
At the moment, no. It's just really sore.
Okay. And does anything make that pain worse?
Just the bright lights.
Ah, so that's why you're wearing those glasses.
I'm not wearing them for fun.
And is there any discharge out of your eye?
No, it's just watery.
And is it tender to touch?
Not tender, but it's just bruised.
And is your vision okay? Can you see all right?
It's slightly blurred, but it ain't too bad.
And finally, is the eye itchy?
No, it isn't itchy.
Thanks for talking to us, Natalie.
Okay, so hopefully you heard that again. Apologies if not. So she had a bit of blurring. She had a bit of a red eye. It was worse in bright lights. The discomfort and pain was a bit worse in bright light, and it watered. She didn't have any stickiness to discharge, and it wasn't itching or burning. So looking at her, she would have a hypopion. So thinking about the infections, you get a hypopion because it's an infection. You've got pus cells there. You can get a hypopion with inflammation. And Natalie, who's young, had acute uveitis. It's also called iritis. It's the same thing. It's interchangeable. So the iris is obviously the bit at the front of the eye. but it's part of the uvea. So there's a sheet of tissue that the iris is part of, at the front of the eyes, the colour part of the iris. Further back, it's called the choroid. So you can get posterior uveitis as well. So that's why you might hear the terms. They're exactly the same problem. It's nothing special. If we treat them with steroids, we'd always start them from the eye clinic. We need to monitor them, because if you give steroids in certain problems, which can cause red eyes, such as a herpes simplex or a cold sore virus in the eye, if you give steroids in those instances, it allows the virus to take off, and then you can get long-term problems. It will sort the redness out, but the virus will then carry on. So even though you might think you've got somebody with a uveitis, we'd always still see them in clinic before we start treatment, just to make sure there's nothing else going on. There's not an infected problem there. However, if somebody's had a uveitis in the past, we do sometimes give people bottles of steroid to have if they're going on holiday, if they're going away, so they can start treating themselves. But we always say you must see somebody within 3 days just to check that it is your uveitis coming back and it's not something else going on. Can cause lender's problems if it's not treated. So that's why we try and get in treatment reasonably early. It's not one of those things we necessarily need to see in the middle of the night, but we would always see within 12 to 24 hours of them presenting if they do come to A&E. Just to give that, just bearing in mind other causes of red eyes, if the eyelashes are turning inwards, these are quite pale, they can rub. So physical, mechanical rubbing can cause problems with the red eye. There was another little bit to my presentation, which I just have to admit, I had computer problems a little bit earlier today. Hasn't saved, but the thing to bear in mind, which I alluded to at the beginning, are systemic problems. So something that's really important not to miss, which might come across, especially in general practice, and other areas are giant cell arteritis and polymyalgia. So if anybody comes in with that's a classic temporal artery pain, discomfort, jaw claudication, and they've definitely minimum age of temporal arteritis GCA is 50. It's vanishingly rare, almost not heard of under the age of 50. So it's not a problem of younger people, but obviously bear it in mind from 50 onwards, and it's much more common sort of 70s onwards. Check the ESR, check the inflammatory markers. If there's no eye involvement, so the eye is absolutely fine, the vision's perfect, and they haven't got any problems, that will be treated by rheumatology on the whole. If they do have eye symptoms, then we would see them. It can be a devastating loss of vision, and obviously high dose steroids are what we do. 3 days of high dose, 1 gram IV methylpred for 3 days. That's the only one I really wanted to mention, to just really remember as a flag up. The other thing is a painful double vision. Don't forget third nerve palsies. Scanning will give us the answer. So anybody who gets a double vision and it's painful and they've got with a headache, think about that. So headaches are often not related to the eyes, but there's just a couple that might be. So GCA, most of you all know about, cerebral aneurysms causing third nerve palsies. And that's really about it, actually. That's really all I've got to say. So I'm just going to hopefully escape that. Oh yeah, that was just to say, do think of us. This is really for medical students, but it's just a little bit of fun. So it just says, if you say, and you're hardworking, if you're really hardworking, whether it depends on what your attitude is to whether you're going to end up being a surgeon, whether you like kids or not, whether you're going to go in peds or medicine. And then if you take the sane side, going right down this side of the algorithm, you can get radiology if you're afraid of the dark, then you go into ophthalmology or dermatology. And then if you're a bit crazy and you haven't got much of attention span, you might end up in A&E or psychiatry.